Hi, what you're about to see are a series of excerpts from a pair of educational modules about dementia and cognition. The things to look out for as you watch are how we used animation in a unique way, using things like characters, stories, humor, mnemonics, and so on to make the experience more engaging for the learner. Enjoy.
Hi there. My name is, yup, you guessed it, Brain.
And I'm Raymond.
And together, we're going to teach you about cognition.
What, you want me to say the dementia part?
Well, yeah, I thought you could finish it off there.
What? Then everyone will think I have dementia.
Okay, all right. I can see how that's problematic. Let's just trade roles and start over, okay?
Okay, fine.
Hi there. My name is...
So first things first, what is cognition anyway? Oxford Dictionary defines cognition as...
And cognition is like a decathlon of different jobs that I, the brain, have to perform. We call these the domains of cognition. The big 5 domains of cognition we want you to learn today are as follows: memory, language, visuospatial, attention, and executive function.
So buckle up! The rest of this video will focus on teaching you how to define and assess these 5 domains.
All right, coming in at number 2 is, what's it called again?
Language. Good one. Now folks, we have an important teaching point here, so listen up!
We want to make sure all of you know the distinction between speech and language. Patients can have problems with either one or both, and it's important that you can communicate to team members about what's going on. Speech is about the function needed to physically make your voice box and mouth make the sounds of clear speech. Language is about receiving, understanding, and producing the intended words and meanings. Let's see an example. One of these 2 patients has a speech problem. The other has a language problem. Which is which?
Oh, yes. That one's called a seashell. It's a seashell. You find the seashells in the sand.
Oh, sure. That's a, it's the, it's, you find it in the sand with the, it's called a,
In this case, the patient on the left has dysarthria or slurred speech, such as from a stroke affecting the nerve to the tongue, while the patient on the right, well, she can't even say what she wants to say. So that one is a type of language problem we call expressive aphasia.
Welcome back to Cognition and Dementia with Raymond and Brain, Episode 2, What is Dementia? Let's go over the learning objectives. Today's learning objectives are: define and differentiate normal aging, mild cognitive impairment, and dementia. 2, to differentiate patients with symptoms of dementia versus delirium. 3, list, compare, and contrast the causes of dementia. And 4, name reversible causes of cognitive impairment. So, dementia is generally defined as a gradual decline in one or more cognitive domains noted to be changed from a prior baseline and which is interfering with activities of daily living. Okay, so let's break this down. First, it's gradual. If someone is fine one day and wakes up the next day with sudden major new cognitive issues, we would not jump to using the term dementia, and instead we need to think about more acute problems like strokes, infections, metabolic problems, delirium, and more. There are a number of things that increase a person's risk of delirium. Here's some things you can do as much as possible to prevent and reduce delirium. We can orient them to time and place. We can help them maintain normal sleep-wake cycles, so open the blinds in the daytime and make the room dark and quiet at night. Assess for unmet needs like pain, discomfort, constipation, dehydration, and urinary incontinence. Take out unneeded lines, catheters, monitors, noisy machines, and so on. Stop or decrease the dose of unnecessary medications, especially ones that have neuropsychiatric effects. Have family present in person or calling by phone as often as possible. Also keep pictures of family members at the bedside. Provide sensory assistive devices. So this is like hearing aids or amplifiers for hearing, and glasses for vision. And by the way, dentures seem to help too. Time the care of the patient outside of those critical sleep hours. Encourage mobility and self-care. Get them moving. Sometimes, sit the patient in the hallway during the day to improve social stimulation. You're probably wondering what the types of dementia are. Here, using our Brainmoji friends, we're going to learn about some of the most common causes. Here we go. So let's start with Alzheimer's. Alzheimer's dementia is the most common type, and yet we actually still don't totally understand the cause. All right, so that was Alzheimer's. Now, the second most common cause of dementia is vascular dementia. That's vascular, like blood vessels. So that's because vascular dementia refers to brains that have been hurt by bad blood flow to the brain, such as from multiple strokes or gradually worsening blood flow caused by things like smoking, diabetes, high blood pressure, and high cholesterol. Maybe the patient has a history of atrial fibrillation, a heart rhythm that causes small blood clots to be flicked off into the brain unless the patient takes blood thinner medication. Okay, so there are also some causes of dementia that have clear extrinsic causes, things that happen to a patient to cause them. Some of these are among the most preventable and sometimes even treatable causes, so they're important to look out for. Our Brainmoji character here is to remind us of one of these causes, which is unfortunately common: alcohol. Drinking excess alcohol over many years can cause damage and shrinkage of certain parts of the brain, with the hippocampus, the key part for memory, being super sensitive to toxins like alcohol. Screening patients with memory decline for excessive alcohol consumption is extremely important, as it's a cause of dementia we can actually prevent. Another cause of dementia that is preventable and sometimes treatable is vitamin deficiencies. In particular, another cause of potentially treatable dementia is chronic infections. In particular, syphilis can live in a person's body for decades after the initial infection and then emerge as a dementia. The good news is, it can be treated with a couple doses of penicillin. While syphilis may be less common than, say, a century ago, it's still a significant public health issue in America today, not to mention the rest of the world, so it is possible you will still care for patients with this delayed neurosyphilis in your careers. Meanwhile, we are now learning that patients living with another infection, HIV, can also develop a form of early onset dementia. We're still learning more about this now that people with HIV are fortunately living longer lives with the help of modern medications. Now, the last cause of what looks like a cognitive decline from dementia is super important. It's sometimes called pseudodementia, and it refers to when depression mimics the symptoms of dementia. Older adults with depression may not come to you crying and telling you they're depressed. Instead, signs and symptoms may be subtle, such as decreased drive to get up and do activities, lack of interest in things, and so on. My point is, if a patient has this hidden depression, they might seem to have poor memory, but when you do a cognitive test with them, what you might find is really low motivation and low confidence, but not as much of an actual problem in the 5 cognitive domains. So with that, here's one last quiz coming your way. Thanks!